I don't need this, do I? So yeah. So Matt sends his apologies. So I'm going to talk about the MCP more in the context of urgent emergency care, which is because that's the presentation that Matt wanted to do. So it's not the normal presentation I give. So you'll have to bear with me if I jump around a bit in the way I talk about it. But I think it's important to start with that we've been doing a lot of work in Dudley to optimise access to urgent and emergency care. So we're a member of a collaborative of 22 CCGs, which is commissioning emergency ambulance services on a collective basis together. We're also been instrumental in the commissioning of the first integrated urgent care service involving NHS 111 with a collaboration of a number of 16 CCGs. Particularly in Dudley, though, one of the things that we introduced fairly early on in the development of our new care model was a 24/7 urgent care, primary care urgent care centre. So that operates alongside the ED. Before we had 2 walk-in centres that operated during the day. We've now got a 24/7 service that's seamlessly integrated with out of hours, and as a consequence of that, it works really effectively in partnership. The clinicians in the urgent care centre work really effectively with the clinicians in the emergency department. They work together to exchange protocols, work around the balance of work between the two. So as a consequence of some of these things and the effectiveness of our local acute hospital, Dudley Group is one of the few places that has consistently achieved the 4-hour standard. They're consistently in the top decile performance in the country. Despite this, and despite 50% of self-presenting cases now being directed through the urgent care centre, even with all of that in place, we still aren't quite now hitting the 95% target. We just missed the target last year. So even though we've been doing a lot of innovation and we've got, I think, an exemplar service in terms of the urgent care centre, we're still struggling to respond to the demand that's coming from our population and the rising, the changing demographics and the rising demand that creates. One of the other innovations that we're now testing, because one of the things that we believe in is that this is not a kind of one start approach. This is a multifaceted approach that we need to adopt. So we're now one of 4 national pilot sites for testing out a new digital innovation. Actually, if you're registered with a GP in the West Midlands, anywhere in the West Midlands, you can actually download this app and use it yourself. It replicates and replaces NHS 111. For the purposes of the pilot that we're adopting, we've actually disabled quite a lot of the features of it. So when it's fully functional, you can use the app to actually directly book appointments through to your GP practice. But at the moment, we're testing this on the basis of its applicability for replacing the way in which 111 works. And one of the things that you can see from this, what's quite interesting, is the age profile of the first people that started to use it. So 56% of the registrants under 36 years old. Also, nearly 60% of them that have used it have been redirected either to self-care, some kind of form of self-care, or back to their GP. So it's kind of interesting to see the percentage of people that are using this and seeing and actually being referred to more, not to urgent care services or referred through to 111. It works in exactly the same way as if you call 111 does, except it does it through, it uses exactly the same algorithms, except it does it electronically rather than through a conversation. So we're testing now, and our perspective on this is that we need to constantly be innovating and looking at different ways of engaging the public and working with the public. And our expectation is that once this is fully up and running, people will be able to use this as a gateway into accessing services. So coming back to the ED, what this shows you is it's, I don't know whether you can see the graph there easily, but the key aspect of this is the age profile of patients who are going through the ED and into admissions, and the type of cases that they are. And what you can see from this, apart from the very high incidence of 0 to 4-year-olds, as people get older, we have more and more people. It's the green piece that's quite interesting. More and more people who are presenting with long-term conditions or multiple complex long-term conditions, but there are conditions that are affectable, so that if we have alternative solutions in place, a lot of those issues could be dealt with in a different way. So it's quite fascinating to see both the volume of that. It's not something that's limited purely to the frail elderly. It does affect all ages, but there are more and more people the older and older you get. And of course, the rising demographic means that's one of the key reasons why we've got significant pressures coming through urgent care, because of that rising demographic of more and more people living with long-term conditions. And one of the things that we did when we first started developing the MCP in Dudley is that we looked at, well, what are the needs of the population and what are their primary interests? And we identified 3 main themes. The first one was everyone at some point wants decent access to services, initially through their GP or through that primary care route. That's one of the reasons why one of the first things that we changed was to create that 24/7 urgent care service that could operate alongside the ED. The second key theme that we've identified with our population is that we've got a third of our population living with at least one long-term condition. So long-term conditions management now isn't an exception, it's a routine, it's part of day-to-day living. And you can see that through this graph in terms of the higher numbers of people who are presenting with a long-term condition as the kind of dominant issue in the ED. Then within that cohort, the third key theme that we've identified is that a rising number of our population are living with multiple complex comorbidities, multiple long-term conditions, and they not only need an effective service to support an individual condition, but they need effective coordination of care. And that's where we've made a lot of changes now with the MCP in terms of the way care is organised, and I'll come on to that in a bit. So one of the other things that we're looking at now is trying to differentiate patients more clearly so that we can start to target initiatives more clearly to different demographics and understand why it is that people are accessing services. So this is taking those same ED patients, looking at their surface usage profiling by geographical area. And what I've done here is just picked the top profile for 2 different geographies. We've actually kind of segmented Dudley into 3 different geographies, not on a locality basis, but on a service profile and usage type. And then we've looked at what are the kind of highest profile groups. And it's quite interesting when you see it. So, if you can see this graph, I'm going to go over here. So, can you hear me okay? We've got a population here whose access to emergency care is high, it's above 24% above the average. Okay, when we look at, but their utilisation of electives is massively below the average, 38% below, outpatients 9% below, and that's in a social group that is predominantly in rented accommodation, unemployed or lower income, smoking, no car. So we can attribute access to the ED in relation to different social groups. Then in a different geography, the highest group there, their utilisation of A&E is 20% below the average, but they have a much higher use of electives, 17%, and outpatients 12%, predominantly employed and higher income individuals. So what we're starting to look at now is that in terms of understanding the utilisation of the emergency department and urgent care, you need to go back to the circumstances, the social circumstances of the individual, understand and then start to target services specific to that population or to that group of people. It's not the solution to the ED is not simply about redesigning the ED and getting the urgent care centre right. It's also about understanding the different populations that are presenting to it, why they're presenting to it, and what the issues are and what their social circumstances are. So we're now starting to look at, okay, so how do we provide a community-based response to the pressures that we see in the emergency department? Does that make sense? I mean, all I've done there is shown you the highest profile uses, but we have the profiles all the way through for each geographical area. And so what we're now engaged in increasingly is this idea that in order to address the issues in unscheduled care, we need to engage the population in their own circumstances and address their lifestyle issues or their particular health issues. This is kind of stuff that people have been saying for a very long time, and it's pretty obvious really, but we can very clearly evidence the different utilisation in different groups but from the data that we've got, and therefore the need to target interventions into different specific populations or with specific individuals. So we're engaged in an agenda which is about how do we target the right outcomes for different populations in our community. And that's really where we're moving to as a CCG now. So we're moving to trying to focus our attention on what are the outcomes we're trying to achieve and focus our providers based on outcome objectives rather than throughput. So we know what the throughput is. But in order to find the right solutions, we need to be clear on what are the right outcomes that we need to achieve for particular populations. And we're moving from a situation now where at the moment, most of our services are funded on an item of service basis through to developing an MCP, which is commissioned on an outcome basis, targeting specific outcomes to different populations. And that leads us to kind of our MCP model. And I'm going to talk a little bit about this and explain some of the elements that we're doing of it. So, on an urgent care basis, you've got this is the hospital, this bit here. You've got the urgent care. You've got the urgent care centre working as part of the ED as part of that model. It's one of the routes of access into the hospital. But in order to more appropriately affect demand in there, we need to have a population-based solution for our community. So we've been designing an MCP on the basis of the person, and that person, one of the core things that's part of the NHS and being, is the fact that you're registered with a GP. So it starts with a person registered with a GP, and then how do we build a community-based response around that? So we've developed in Dudley multidisciplinary teams. That was referenced in the previous presentation. It's really quite simple. So what we've established is the important thing to do is maximise the potential of our frontline staff to work as effectively as possible as they can together. So if you go back to the population needs, and we've got more and more people presenting either with long-term conditions or more particularly multiple long-term conditions, what they need is a coordinated response. The only way that our staff on the front line can deliver that coordinated response is if they actually work together as a team. So to work together as a team, you need to structure them in teams. It's pretty simple. But when we first started on this journey in Dudley, every single community service was organised on a different geographical basis. So the district nursing team were in 14 groups, social workers I think were in 5, mental health workers were in 3, etc., etc. We had 46 GP practices. So our frontline staff couldn't work together as teams because they weren't structured by their organisations on the same organisation in a structural basis. So we took a step, very, very simple step. It was one that a lot of people struggled with because everyone had to reorganise themselves, so that all of our community and social care services are based on the same geography. What that does is it empowers our teams to work effectively together. So we now have the person registered with a GP supported by a multidisciplinary team, and it is a genuine team. We call them teams without walls because they're teams of people from different organisations but working together in the same geography. But because they're working together, what they can do is they're empowered to work effectively with each other. So most of our staff now report extremely positive morale because they feel that they can make a difference, because if they've got a patient who there's a problem which they can't deal with, they know the person who can deal with it. And instead of having to, in the past, call through to a call centre or an answer machine to get access, they just speak to the person. They know they're part of their team. So we're seeing massive improvements in staff morale and also in the patient's response to that way of working. The other thing that we've done as part of this multidisciplinary team approach, going back to that point about we need to be able to target this much more effectively to different populations, is we're trying to create a culture which empowers the teams to take responsibility for themselves so that they can affect those differences and they can respond differently given whichever population they're part of. And in particular, we've included, it's one of the few areas in this where we've put additional investment, we've included link workers who link this team into the voluntary sector. When we started on this journey, we thought there were about 800 voluntary organisations in Dudley. It turns out there's over 2,000. And the wealth of skills and resource that there is in the community is massively misunderstood. It's certainly not utilised effectively, and creates significant opportunity. So now we have MDTs that are connected in to local communities as well as professionally connected to each other. We can evidence that some of our more complex patients who have multiple comorbidities, their utilisation of primary care services and community services is reduced by as much as 30%, because we're providing a much more holistic response. We're providing a response that connects them back into their community, links them into local voluntary sector organisations, helps to understand that the person is part of a social network, helps to understand what are their social circumstances. So that example that you so eloquently gave us earlier kind of illustrates, that woman, her needs were as much social actually as they were medical, and by addressing her whole needs, you actually get a completely different response. The one thing that we haven't quite yet been able to evidence is that change in community then has a consequential impact on demand for urgent care. I think we're still at the early stages of being able to evidence that. But we very much believe that if you're looking at this from an urgent care perspective, the way to address the pressures that we face in the hospital and the way to address that long-term increasing demand in emergency admissions, first of all, we need to get the system right around urgent care, which we've been doing. And we need to innovate that as much as we can. But then we also actually need to address the challenges that people face in their own social circumstances in community. And by getting that right, we think we can develop a whole system response which is sustainable for the future. So that's what we're trying to achieve with the Dudley MCP. Thank you.